think a lot of it is like we haven't been educated, we haven't been informed. It's not like, you get a period class when you're like 10 to 13. Like, where's the perimenopause class? Like, people want to sign up for that, So it's like, what do we need to know for that next season? And so I think it's just, we're so hungry for information that by the time we get to you, we're like, Robyn, I need this yesterday.
Right? No. Oh, yeah, absolutely.
Welcome to Modern Menopause, a podcast by Parlor Games. I'm your co-host Morven. I'm a certified therapist and I'm one of the Parlor Games team members. And today I'm with my co-host, Dr. Robyn, who is our consulting physician and all-round expert on everything menopause, and our very special guest, Dr. Sara Reardon. Dr. Sara Reardon is a board-certified pelvic floor therapist, but you might know her as her more common name, the Vagina Whisperer. She has a ton of awesome stuff. She has a book, she has a TED Talk, she has an incredible app, which we're going to be talking about today. And she's joining us while we give her some questions all about pelvic floor health. So welcome, Dr. Sara and Dr. Robyn.
Thanks for having me.
We're
Super
very
fun
excited. Yes. And actually, I was telling Dr. Robyn before you came on, my first interaction with you or first awareness of you was on Instagram, where you were dressed as a giant vulva in your giant vulva outfit, which I think has become pretty famous, right? I think people know of this outfit.
It is, and now I have a closet of vulva. So I'm like, which vulva should I wear today? So it is, and it really became this way to bring levity and lightheartedness to talking about a topic, our pelvic health, our vaginal and vulvar health, which are topics we just don't talk a lot about, yet we should, because it's part of a woman's body, it's part of healthcare. And so it's just been a really fun way to kind of just bring lightness to this topic that I think often we feel embarrassed or ashamed about, but it's just another body part like any other part of the body.
I love it. Yeah. So now can I ask, just because you mentioned this and now I have to know, do you make these? Does someone else are these custom made vulvas that are?
I don't, Morven. I am the least crafty person out there. I like to outsource as much as possible, actually. So when I hit 10,000 followers on Instagram many, many years ago, my sister, my twin, who's in marketing, was like, you need to do something really big. So we just started looking for these goofy costumes online, and we found this vulva costume. And it was around 2018 where there were a lot of women's marches going on in the United States. And so we bought it, and it was like $150. And has now become the kind of this image of the brand, which is so fun, but they don't make the costumes anymore, which is so sad. So I've got like a bunch of different felt vulvas from other makers, but I don't make them myself.
Nice. Very cool.
Love it.
Okay. Well, Dr. Robyn and I, we talk about pelvic floor health a lot, right? It comes up, obviously, we talk about hormones. We talk about, women who are experiencing various different types of pelvic floor dysfunction. Obviously, a lot of our ladies are in perimenopause, menopause, I would say generally, right, Dr. Robyn? Mm-hmm. What are some of the most common pelvic floor issues you're seeing in women, specifically in sort of perimenopause or menopause?
So, we know that perimenopause, peri means around, so it's pretty much any time around menopause. We consider it, the way we talk about it, as the time before menopause. We know perimenopause can start up to 10 years prior to menopause. So if the average age of menopause is 51, it can start as early as your 40s, definitely even into your late 30s. And I think a lot of moms now are having babies later in life. So we go from this like blurry postpartum phase into this early perimenopause phase. And we're like, what is happening? So a lot of those symptoms can blend together. The most common ones that we see are urinary leakage. So it could be a little bit of leakage with like a cough or a sneeze, or now every time you jump or run or laugh or have a full bladder and can't make it to the bathroom in time, you start having leakage. More frequent urination. So this could be waking more at night to pee, having to pee multiple times before going to bed, or, maybe you used to be able to make it to 2 Zoom meetings, and now you have to go in between each one, so urinating more frequently, and painful sex. So, the tissues in the vulva and vagina start to get drier and thinner and more sensitive, and they can cause pain with intercourse. And so those are kind of some of the signs that we start seeing in this stage of life. And I think sometimes women are like, oh, maybe it'll go away or maybe it'll get better. But these issues don't get better, unfortunately, because our bodies are just getting less and less estrogen and testosterone and progesterone. And so it's kind of only going one direction, which is why I'm so excited to talk about what we can proactively do to address pelvic floor changes and like what's normal and what's not and what you can do to address them if you have them.
Well, I think for a lot of women, they also tend to ignore it, right? Because they think it's normal and like everybody has to experience that. Before I went to med school, so moons ago, and I was working for a physical therapist in a very small town farming community. There were 10,000 people and more cows than people. And she was actually doing pelvic floor health. So this was like my first foray into that area. And so I'm curious, and I'm sorry if I kind of sideswiped you, Morven, but for women, who have kind of lived with this stuff, they think it's normal. It's been the norm. Back then, this was unheard of. People didn't go to pelvic floor therapy. Nobody knew what it was. So I'm wondering, with that kind of evolution, now we're decades later, are you seeing more women seek pelvic floor health or seek help for pelvic floor, or even more doctors and practitioners bringing it up for them, or what are you seeing there?
Both, Robyn. So I definitely see more women advocating for this type of care. I think we've done a really amazing job as pelvic floor therapists, whether it's on social media or through different kind of aspects of the internet, podcasting, whatever type of media is out there. We have been really passionate about telling women hey, this is available. Like if you leak urine, if you pee your pants, if you have prolapse, if you have painful sex, there is help available. You don't have to just deal with it. So I've seen a huge percentage of women over the years, I would say the past 5 to 10 years, really start to proactively seek it out for themselves and start to go to therapy. But then I also see medical providers start to kind of shift of if somebody's got vaginal pain, they can go to pelvic floor therapy. Or if someone's got, they're in perimenopause and they start leaking more, it's they should be going to pelvic floor therapy. And so we're starting to see the medical system change. And so it's been kind of bottom up, much like a grassroots, calling of hey, we need this. And now I see top down medical providers saying oh, this is what you guys do. Okay, we're going to start sending patients. It is still not where it needs to be, though. I mean, I think that the way that I see pelvic floor healthcare is it should be like going to the dentist. You go once or twice a year for a check-in. You are automatically referred when you are pregnant, postpartum, in perimenopause or postmenopause. And you have regular check-ins because we know this part of the body is changing. And it affects so much of our daily lives, not just, exercise or sex, but everything from core support to breathing to movement to sleep to, travel to everything. And so I think if we can start, talking about it and having these conversations, people can start to see, oh, this is something that maybe I need, but also my patients need it. And I should really be referring them much sooner.
I love that. Like dentist.
Yeah.
Yeah.
Well, that you mentioned something interesting there, right? Which is I think true for all women's healthcare, not just this. That it sort of starts off in this sort of grassroots movement from the bottom up versus from top down. But obviously, I think we see this definitely with menopause and perimenopause, is that a lot more women are talking about it on social media. Yeah. And there's a lot of great things about that. We're also seeing some things that are not so great, where we're seeing a lot of sort of misinformation or just stuff that's a little bit off. What are some things in terms of, because there's a lot of pelvic floor advice, right, going around out there. Do more Kegels, just do 1,000 Kegels a day and you'll be fine. What's sort of helpful? What's harmful? What's some of the advice that you've seen where you think, oh, I'm not sure about that one?
It's so difficult because, I share a ton of information on social media as well, but there is so much nuance to what we do. So it's easy to say, if you leak, do Kegels. If you have pain with sex, do relaxation. It's not so black or white. It's very nuanced, and every person needs something a little bit different. So one, I think some of what we want to do is help people see if you're experiencing these problems, you don't have to deal with it, but there's no one exercise that's going to solve your pelvic floor problem. So there's so much nuance and individuality to the care that we provide. I think so, but I also think that we want a quick fix. People want a vibrating chair, a laser wand, a shot, a pill, a cream that's going to make everything go away, and that is just not the case. I mean, pelvic floor physical therapy is therapy. You don't go to one visit of therapy and things are fixed. It is learning how your body works, making changes to improve it, and then getting long-term maintenance strategies to help, keep symptoms at bay. But if they come back, then you go back to therapy. So I just think that some of it is it needs to be more nuanced. Like, we need to understand that there is no one size fits all. There is no quick fix. Even these quick fixes of, like, chairs, 1,000 Kegels a minute, like, that's short term. There is no long term solution to health except for exercise, diet, nutrition. I mean, so it's like you have to put those pillars in place to be able to sustain these things long term. And I think you also need to look at who's giving you the information. I think if it's a person who was pregnant and had a baby and they went to therapy and now they're telling you everything that you think you should be doing, like, you need to look at individuals who have these credentials and this experience, not just someone who maybe went through that or took a weekend course and that's who's giving you your health advice. But I don't blame people for wanting to figure this out. I think there's a lot of doctors and medical providers on social media that say like, oh, everybody's going to Chat GPT for their healthcare advice. I'm like, well, that's because our healthcare system is broken. Mm-hmm. That's because it takes us 4 months to get in somewhere and it costs $2,000. So, and for a 5-minute visit where we feel gaslit. So if we can change the systems to actually be effective to help people, well, then we're not going to go to ChatGPT, or we're not going to go to the influencer on social media. So there's a lot of work to do at the system level. It's not all just on the individual who's like following the new person with pelvic floor exercises.
Sure. And that kind of echoes what you said, right, Dr. Robyn, with sort of women coming in when their hormones are out of whack and their cortisol, and they're sort of like, how do I fix it today? How do I, what do I do today to make my menopause just better?
Yeah, so more than just a today answer. Yeah.
And, I think though, Robyn, what's so hard is that, like, if we give people a heads up as to what's coming, they're going to feel more in charge versus
Absolutely.
like, then it feels like everything is being done to this, and then like the passengers in our healthcare journey versus like the drivers. And I think a lot of it is like, we haven't been educated. We haven't been informed. It's not like, you get a period class when you're like 10 to 13. Like, where's the perimenopause class? Like, people want to sign up for that, So it's like, what do we need to know for that next season? And so I think it's just, we're so hungry for information that by the time we get to you, we're like, Robyn, I need this yesterday.
Right? No. Oh, yeah, absolutely. But what's interesting, and what I've kind of a benefit I've seen come out of all the social media talks and influencers and things, is people are starting to do that on their own. My patient demographic has shifted, whereas historically it's always been like 40 plus, what's happening to me, what is this? I'm starting to see women in their 30s, more women in their late 30s, early 40s saying, what do I expect? Can we get ahead of this now? And I love that. That's like my favorite thing to work with, and starting to see more women become empowered and educated, and even if it's one person at a time versus our, perimenopause health class that we should all be having. But it's nice to see the shift change.
It's wild. There is so little. I remember when I was pregnant trying to find a video that showed like a full frontal, is what I called it, of a woman, of like a baby coming out of a vagina. And I couldn't find any. I found one video of a brave woman that was on all fours, which was incidentally how I spent most of my labor. And it was a shot from behind. And it was the only video online that I could find of a woman, because I was like, I want to see what is going to happen. And then my mom was at my labor, at my delivery, and she has had 3 children and had never seen a baby be born. And I was like, man, that's crazy to think that, like you say, Dr. Sara, after the period talk, women, it's like, you get information about your pregnancy, but you don't really get information about your vagina, right? And your vulva. You get information about, like, this is what's happening to the baby. Oh, you have more blood volume, or your temperature might change. But no one is really telling women, like, hey, this is what happens. I think to your body as a whole, to your hormones. But I think kind of specifically to your vagina, I think there is this weird, we're not going to mention it. We're going to talk about babies. We're going to talk about menopause or perimenopause, but we're just not going to mention the word vagina. It's like a secret, and we don't know what happens to it. And this is something that I think it makes it challenging for women, right? Because they're not being told, like, hey, your skin ages, and that includes the skin in your vulva. What about habits that women might be doing that can sort of wreck their pelvic floor health? Because I think that is one of the things, because we don't talk about it, we don't really know, kind of like we've talked, Dr. Robyn and I have talked about shifting, like, hey, you need to do weightlifting exercises as you get older to help your bone health. As women get older, as they go into perimenopause, menopause, what kind of stuff is helpful for the pelvic floor? What kind of stuff is harmful that women might be doing that's, hey, maybe this is actually hurting your pelvic floor health?
So to start with kind of what's normal, I think that teaching women how to pee and poop and lift are the three things that I tell everyone. Like, we're never taught how to do these things. So like those are things you do all throughout the day, and they can significantly impact your pelvic floor or be indicators of a pelvic floor problem. So for peeing, I always tell people, like, go when you have the urge to go. Don't go just in case. And the normal frequency to urinate is every 2 to 4 hours during the day and 0 to 2 times at night. The other thing is don't hold it for too long. Sometimes if like teachers, doctors, moms, people who don't pee in public, if you're holding it for too long, that can actually cause a lot of tension in your pelvic floor, and then you don't empty your bladder well. And then when you do pee, like, don't hover. Sit down on the toilet, lean forward, take some deep breaths, and don't push. Just like sit, chill, and breathe. Pushing when you pee can weaken your pelvic floor muscles over time and lead to pelvic floor problems. And I think as moms and women, we're so efficient and always like, what do we have to do after this, right? And so we're like pushing to race through our pees, and that can cause pelvic floor problems. So those are the things I say, like sit, chill, breathe, and don't push. For pooping, I tell everybody, like, use a squatty potty underneath your feet, like a little step stool under your feet to put you in the squatting position. Keep your poops nice and soft with like good fiber-rich foods, regular exercise, lots of hydration. You can take like magnesium citrate or glycinate to help soften your stool, because straining with bowel movements can weaken your pelvic floor more than jumping, coughing, sneezing, crunches. So if you're straining to poop, you're weakening your pelvic floor, and what's normal to poop is like 3 times a day to 3 times a week. So like learning how to poop properly is important, and then learning how to lift. There's so much great information about the importance of strength training and lifting weights during this phase of our life, but we have not been taught how to do it to optimize our pelvic floor health. So I teach people to exhale with exertion. Like when you're lifting weights, you should not be holding your breath. When you're lifting something, your body takes on that load and your pelvic floor takes on that load. And if you're holding your breath, that pressure has nowhere to go. So it's going to go towards its path of least resistance, which for people with a vagina, it's down towards your pelvic floor. So you should exhale when you lift. So I'm like, if you're lifting weights or lifting your grandkids or lifting a heavy box, breathe out as you do it. And then you need to be bringing pelvic floor strengthening into your workout routine. So like when I do squats and lunges, and I coach people on how to engage their pelvic floor first before they lift, before they do a squat, before they do a lunge, before they do an overhead press, to kind of get them used to turning those muscles on. I think one of the biggest things is you have to build the foundation of your body, which is your pelvic floor and core, before you lift all of these heavy weights, before you walk with a weighted vest, before you do your jump ropes. Just like when you're postpartum, you've got to rebuild that pelvic floor and core, and that same thing has to happen in perimenopause and menopause. So I encourage folks to take, those 6 to 8 weeks to really do that deep pelvic floor and core strengthening, and then start loading with heavier weights and more resistance and impact if you haven't been doing those exercises previously.
Nice. Those are good ones. I did not know that you didn't push when you pee.
I know. It's like
I routinely am like, I've got to go. Someone's waiting for me outside the door. I've got to pee as quickly as possible because there's a child going to bust in.
Totally. And I can't tell you how many people are like, Sarah, every time I pee, I think of you. And I'm like, great, because that's what I want. But we're never taught how to do that. And I've met women who've never had babies before. They could be in their 20s and they've pushed when they're peeing their whole lives, and now they have pelvic floor problems. And so, we pee 6 to 8 times a day, and if you're doing it improperly, it can affect your pelvic floor. So easy, small changes like that go a long way.
I like that. That's a good one. Okay. Well, I was thinking one thing that would be interesting, Dr. Robyn, if you want to kind of dive in on this one, is we actually have some scientific articles about this, right? Is as pelvic floor therapy is becoming sort of more widely known, the role of sort of estrogens in the vagina, the role of estriol. So Dr. Robyn, for our listeners, can you give a little bit of insight into kind of the role of estrogen, estriol, estradiol in and around the kind of vaginal and vulvar tissues?
Yeah, absolutely. For me, a lot of the women that I see, like I was mentioning, they're perimenopausal or menopausal. They're already starting to have symptoms of lower estrogen at the vulva and vaginal tissues. So there's discomfort, but I tend to screen everyone for signs and symptoms of pelvic floor dysfunction. So I do a lot of referrals that way. And oftentimes that referral is going to take a little bit to get in with somebody, right? So we tend to start the vaginal estrogen therapy first, just because, it's going to be faster, and then it's going to help make that therapy more comfortable for somebody and ideally more effective. So as we lose our estrogen declines, we start to see actual tissue changes. So there can be dryness, thinning tissues, tissue tears. We can have some decrease in blood flow. And as we bring the estrogens back in, we can see, improvement with blood flow and helping the muscular tone, increased thickness of the tissues, increased moisture. And so we're starting to really rebuild that tissue with, increased collagen and everything as we bring it back on board. So not only is it more comfortable, which I think a lot of times people will say, well, I'm not having sex, I don't need it. Okay, well, maybe it's not just about sex, and it's about pelvic floor health and our bladder health and decreased urine leakage and better pH and microbiome for the vagina. So it's doing all these things for tissue health and vaginal health outside of comfort.
Okay. And then I guess from your end, Dr. Sara, what are sort of tools that, because there are a lot of new tools on the market for pelvic floor health, right? There are estrogen creams, estradiol creams, but there's also you kind of mentioned at the beginning, right? There's the apps. You can insert something and you squeeze it and it gives you kind of biofeedback. Dilators are kind of different because they're typically for a specific reason. But are there tools that you're seeing that you're like, hey, this is effective, this is helpful? I know you're saying it's individualized, right? It's a case by case basis, but are there kind of more tools available to women now which are going to help assist the pelvic floor therapy process?
Yeah, so I always say that pelvic floor training and estrogen are the goats for your pelvic floor during perimenopause and postmenopause. Like, there are two things that every vagina and pelvic floor needs, and it's those two things. And I think it really should be something that every person in perimenopause is using, because I see it. I look at tons of vulvas and vaginas and test pelvic floors every day. Every day I'm in the clinic. And I don't think people realize the changes that are happening, just like you see them in your hair and your face and your skin. Like, that's the same thing that's happening to your vagina, vulva, and pelvic floor. And using a estrogen patch or cream or pill is not going to target your vulvar, vaginal, and pelvic floor tissues the same way as a local cream. So you have to be using a local cream on the area, but you also need to be doing strengthening of your pelvic floor. And so, there's research that shows that after the age of 35, you lose 2% of your urinary sphincter strength every year. 2%. And so, no matter where you are, you lose 2%. Because think about how our muscles get weaker and atrophy over time just with aging, right? Like, you hit your physiological peak, and then things start to change. And especially as your estrogen changes, estrogen helps plump up those pelvic floor muscles and tissues. And so you have to proactively start strengthening these muscles to maintain that tone, to support your bladder, to support your bowels. And at the age of 65, 50% of women are leaking urine. And that's not because it's like, oh, they've had babies. It's like, no, it's because our muscles and tissues aren't performing the same way. So you can't just use estrogen. You can't just use strengthening. You have to use both to really get the most benefit and to prevent some of these issues from happening, like, leakage or prolapse or dryness or painful sex, but also to prevent UTIs, to prevent frequent urination, to help with fecal incontinence. There's other things that we don't talk about. It's not just sex. And so I think that helping women understand the importance of that, just like we talk about, you've got to do weightlifting for bone density and you've got to do cardio for heart health. Like, you have to do your pelvic floor training and use your estrogen for your pelvic floor health and your vaginal health. For many, many reasons. And I think we just aren't giving women that education proactively.
Yeah, that's a good. And for our ladies listening, if you're like, hey, where the hell do I find things to proactively deal with this stuff or to find a workout routine for my vagina, Dr. Sara has an amazing app. It's called the V-Hive. You can find it. You can actually use a code. It's Parlor, P-A-R-L-O-R, all caps, to get a 30-day free trial with Dr. Sara's app if you're looking for a great vagina workout. So if you're listening and you're like, hey, wait.
And I think people are like, what is a vagina workout? But it's really teaching you how to strengthen your pelvic floor with, lifting weights, with core exercises, with squatting and lunging and functional tasks that you do throughout the day. And so There's a specific perimenopause and menopause program in there with weekly tips on like what's happening, why is sex feel different, what are the urinary habits I need to know, what happens if I go through surgical menopause and after a surgery I wake up and my hormones have changed, what happens after breast cancer, what happens to teaching women how to do monthly vulva checks. So are your labia changing? How does your clitoris look? Like, how do the tissues look? And just helping people get really oriented to this part of their body, because we have another 40 to 50 years after we hit perimenopause that we need to be living our best lives. And I want people to be able to travel and exercise and feel good in their bodies and not have this kind of under the cover, behind closed doors challenge that I think so many women have, but they don't know where to get help for.
I was going to ask about this because you mentioned sort of clitoris changes, and this is, I would say, Dr. Robyn, would you say this is our one of our biggest questions is about libido. It's we get it all the time. Like a lot of women in perimenopause and menopause, contrary to what the media tells you, they want to have sex, they want to enjoy it. They're still in intimate relationships with their partners. And obviously hormonal changes can shift, and one of the things we get a lot of questions about is low libido, but also sensation changes. Women are like, hey, I'm not having orgasms, or it's much, much harder to achieve an orgasm. What do I do? And they sort of want Dr. Robyn to fix it today, understandably. Right now, on this podcast, fix it. But I'm assuming you get this as well, right? Women who sex was previously good. This is different, I think, from women who are postpartum where, there's been a lot of physical change, or women who have, vaginismus and it's sort of been an ongoing challenge. This is women who, hey, for the past 20 years, I've had a great sex life with my husband. And then bam, even if there's not GSM, vaginal atrophy, right? And it's painful, I'm just not getting there.
Yeah.
Does pelvic floor therapy play a role for women like that who are sort of like, hey, it's just me?
Yeah. So what we see, the clitoris is the bulb. It's a purely sexual organ. There's 10,000 nerve endings there. There's a lot of blood flow and sensation to that area. And the majority of women have orgasms through clitoral stimulation. So we need a lot of really healthy blood flow going to that area. But when you have an orgasm, your pelvic floor muscles, there's two layers to them. There's an outer layer and there's a deeper layer that's like a basket or a bowl. But that outer layer, those muscles are the muscles that contract and relax during an orgasm. So if those muscles are weak, you will feel less of a contraction. You will feel a weaker orgasm. And so these are muscles like every other muscle. Like you've got to strengthen them, you've got to use them, you've got to get good blood flow to them. They have to be well estrogenized. So all of these things are important pieces of information for women to understand. There's also something I think we also need to think about the role of our central nervous system is changing. We may be taking a medication, like 30% of women are on antidepressant or anti-anxiety medications that can also affect libido. So I think thinking about those external influences that could be affecting our drives and desires, but from a physical perspective, your pelvic floor is directly related to orgasms, sexual health, climax, sensation. And so I think we need to make sure that we address that piece, that we want these tissues to be healthy and strong and contracting and relaxing, the way that they always have been, and all of a sudden we need to change. Like we need these tissues to be well hydrated and not dry and to have good blood flow. And so I go back to pelvic floor training and estrogen. Those are and moisture, moisture to the area. Those are really the goats for your vagina and pelvic floor and orgasms.
I love that. And what I really like about that is we didn't say anything about testosterone. I'm not saying testosterone doesn't influence and help, but everybody wants that to be the answer. And that question comes up all the time. And there's so much more than testosterone.
There's so much more. And I think it's one of those things that I think when we get to that point, we're just grasping for straws. I mean, I feel that myself. So we're just anything that we feel like can help, but it's so multifaceted, and by the time we hit this point, I think it's just just give me anything. But there's so many things that kind of go into these hormonal shifts. But again, they're not being explained to us; they're kind of happening,
right.
And all of a sudden we're like, wait, sex doesn't feel good, or I can't have an orgasm anymore, or it's like my vibrator's not doing what it used to. But there's these influences, but there's also solutions, and that's what I love that we're really providing for people. And to circle back, back to the dentist analogy, we don't fix a cavity and just stop brushing and flossing our teeth. There's like maintenance that needs to be done for long-term health.
I like that, yeah. I also like the word estrogenized, which I'm going to be stealing. Absolutely. I'm just going to be straight stealing that.
Please do. I don't know if it's a word. I just made it up. So
I make up words a lot to kind of fulfill our bill, so it works really well.
I have a question, if that's okay with you, Morven. I'm going to pop in here.
Fire away.
You know, we've talked a lot about, obviously, pelvic floor therapy, but even in practice, and I'm not doing exams anymore. I'm fully online, but even, when I was or still referring people now, I find that a lot of my patients, even though we talk about it, we talk about what the experience might be like, they're still hesitant to go. I remember one woman in particular, I think I talked to her 3 times. I put the referral in, sex was painful. She had low back pain. Finally, she went in when her PCP urged her to do so. And she came back. She was like, I can't believe I didn't do that sooner. So there's still this little, I don't know if we want to call it a stigma, but some hesitancy there. So I was hoping you could speak to like what actually happens at pelvic floor therapy experience and what you would say to somebody who is hesitant to go.
yeah, absolutely. And I think that if 67% of women who are referred to therapy, only 67% actually attend. And so it's like that's just not a great enough number where we're like, okay, there's 1 out of every 3 women is not getting the support that she needs, and or all genders actually. But when you go to a pelvic floor therapy appointment, they're usually between 40 to 60 minutes, one-on-one in a private treatment room. So you're not kind of in a big physical therapy gym. You're with, one therapist who's, taken credentialed specific courses for pelvic floor therapy. And a lot of the first session is just talking and getting more information about the patient. So you may be there for painful sex, but I'm going to ask you about your childbirth history, surgeries, hormones, exercise, peeing habits, pooping habits, everything, your menstrual cycle, to get a really kind of clear picture of your overall pelvic health. And then with that information, I'll do then an external assessment. So this can be with clothes on, and I look at your low back, I look at the range of motion of your hips, I may kind of touch on your abdomen or see if you have any abdominal scars or incisions or anything like that. And then I step out and let you get changed, and you undress from the waist down, so pants and under are off the bottom, and you're covered with a sheet, and you lay down on like a nice mat. I use real sheets. I think it's important for folks to be comfortable. And then I do the pelvic floor and vulvar assessment. So I'll pull the sheet back, and just like when you're at the gynecologist, but I'll look externally first. There's no stirrups. Your feet are just kind of resting on the mat. And I'll look at, did the tissues look healthy, de-estrogenized, like how are things looking? Are there any asymmetries? And then I'll ask the patient to contract, like they're doing a Kegel contraction, and then relax. And then I'll ask them to push out or bear down like they're having a bowel movement or pushing out a baby. And then I'll ask them to cough. And that just gives me a good idea of how is their pelvic floor working? Are they able to contract? Are they able to bulge? And then I'll do the physical assessment where I press on the outside of the pelvic floor muscles, that superficial layer. Then I'll insert my finger with a glove lubricated finger into the vagina, and then I'll press on the side walls to look for tenderness in the muscles. And then I'll ask them again, contract, relax, push out, bear down, and cough. And all of that does is, that internal exam helps me access the pelvic floor muscles because, again, they're like a bowl of muscles. But it lets me know, like, is this person have weakness? Do they have tension? Do they have incoordination? Is there another medical issue I need to maybe refer them out for? So it's just assessing the muscles. And then they get changed and we say, okay, this is the plan. We need to work on strengthening. There's some weakness in the area. There's some low endurance. And then we kind of start them on exercises, or we may start them on relaxation and breathing and stretching if it's a tension issue, kind of things like that. So I think there's just a lot of, I wouldn't even say stigma, it's almost fear. It's kind of fear of the unknown, like what is this going to entail? There doesn't have to be an internal exam. It's totally up to the patient. Like, you can opt out of it, and there's plenty of things that we can work on. But I think more than anything, what I like to stress with patients is, like, we're just here to help you understand your body better. Nobody's really educated you on how this works or what's going on. And we just want to be able to say, is this a muscle issue? And if it is, there are solutions to help you. So that's really our goal of therapy. And then, sometimes it takes 4 to 6 visits. We give you things to work on at home. You can bring a partner with you if you'd like. So there's a lot of things that But a lot of it's just education and teaching people about how their body's working and why something may be happening. And it's really muscles. Like pain with sex sometimes can just be like a muscle spasm of the vagina. It's that simple. Or leakage can just be weakness of these muscles. So it's like any other muscle in your body. It's just we access it through the vagina.
Yeah, really helpful for women who might be on the fence about going or, didn't know what it entailed.
And I think especially with our demographic, there's women who are, in an older demographic, and I think this is a subject that's sort of been pushed aside for a lot of years, and even still to this day, right? I think a good question that we deal with a lot is how much women are told to just deal with these symptoms, whether that's hot flashes, whether it's poor sleep, whether it is some leakage, whether it is painful sex, low libido, having to pee more, even like incontinence. Women are told to kind of just deal with these things. Why do you think that is? I know this is a big question. I know it sort of goes into a lot of these things, but, Dr. Robyn and I have discussed this, I think more with hot flashes and sleep and stuff, but how common it is for women to be told like, oh, that's normal. And that's sort of one of the big challenges that we have, is that we come across a lot of women who just think, oh, well, this is normal. And then it's countering that belief that, sure, some of these things are parts of aging, which is technically normal. But what's your sort of take on that? Because I'm guessing you see a fair amount of that as well.
Yeah, I mean, there's so many layers to this. I mean, I think that women are gaslit in medical appointments way more than men. I think that women are not, we just, in the past 3 decades, have been the one who've actually been studied in the research, versus we always say like the research is done on men and they shrink it and pink it and be like, oh, this could work for women too. So we haven't been the focus of healthcare and research studies for even until the 80s. And so, I think that those are kind of some of the like bigger systemic issues. But the reality of it is like we've never been taught about this part of our body. It's been something that like we don't even call it by its name when we're raising a young girl. We call it a cookie or a cha-cha or a coochie and I'm like, you don't call an elbow like a corn. I always tell my kids, like, they're like, why can't we call them nuts? I'm like, because they're not nuts. They're testicles. I'm like, I don't call my elbow a burger. It's like, call the body part by its name. And so I think of some of that as like, we've been fed this narrative of we don't talk about this part of our body. We should be ashamed of it. We should be embarrassed. We should slip tampons up our sleeve because we want to pretend like this isn't happening, but yet every person is going through this. So I think that's one thing, is that we've been fed like we should be ashamed, embarrassed, and hide these issues. And then the other thing is, once we work up the courage to finally go talk about it with a medical provider, we've been gaslit, we've been dismissed because they haven't been educated on actually what's happening in a woman's body in the healthcare system. Like, we can say OBGYNs are responsible, but like do they deal with everything in a woman's vagina? It should be like primary care, it should be OBGYNs. I mean, I've had dentists refer patients to me for pelvic floor issues, and so it's like every medical provider who is seeing somebody who has a vagina should be able to screen for these questions to say, you might need to go see a pelvic floor therapist, just like we screen for mental health issues. And so I think that that's one of the things we need to be aware of. And then the other thing is, unfortunately, I think as women, we white knuckle our way through a lot of really tough experiences that we go through, particularly when it comes to our health. And we don't have the support systems and social structures to help support us through postpartum or pregnancy or perimenopause and menopause. It's like we've always just been like, put your head down and kind of battle through. And so therefore we do that when it comes to our health, but it affects our quality of life so significantly. And we're just now like, wait, I shouldn't have to deal with this. There is a better way. I deserve better care. And so we really have to advocate for ourselves, because it's not going to fall into our laps. Like, we have to be the ones to fight for it. But that's hard. It's hard. It feels like a little bit of David versus Goliath. But it's absolutely necessary, and it's absolutely worth it.
Yeah. I hate the whole naming of the body part something else for slightly different reasons than you. As a therapist, I'm like, no, just always teach your children the correct clinical names. But I've told Dr. Robyn this. I taught my daughter from a very early age. She's 7 now. But she decided one night at bath time to give my mum, her grandma, like a really in-depth anatomy lesson. She was like, this is my vagina. Do you know that there's a hole where a baby comes out and it's not the pee hole? And my mom's like, I do know all this. My daughter's like 4. She's like, why do you know all this? And mine was like, yeah, I told her. Yeah.
I mean, it's amazing for someone to understand how their body works and to not feel ashamed of it and to be proud of it and to talk about it in a way that's not purely sexual either.
Right.
And I can imagine as a therapist, I mean, even my kids, you know, I'm always like, when they talk about, you know, I don't even like to say private because I'm just like, it's our body parts, but that we call it by its name. And I want them to understand how my body works as a woman. Like, I don't think that I need to shield from them, like, mommy has a period and blood comes out and it doesn't hurt and this is what it means and this is how a tampon works. Like, they're 2 boys, and I'm like, sorry, kids, you're the children of the Vagina Whisperer, so you're going to know a lot more than the other little boys out there, you know? But I'm like, everybody needs to know this, you know?
Right.
So I think to your point, it's amazing you're teaching your daughter this because our parents' generation, they didn't have the luxury or the freedoms to talk in the way that I think we are doing, and that we hopefully change for the next generation to do as well.
Well, yeah. And to that end, you know, for women who are maybe in more remote places or women who don't have this access, you obviously have the app, you have the VHive, you have the book Floored. Tell us a little bit about, you know, for women who might not be able to get a referral, for women who might not be able to get to those things, what kind of things, you know, if they were to buy your book, if they were to go to your app, what kind of things are they going to be able to access if they maybe can't come in for an exam, if they're in a remote place or they're just really uncomfortable, you know, like if it's someone who's just like, hey, I'm not there yet.
Yeah.
Using something like your app, reading your book, obviously might give them access to tools that they might not previously have had access to at all. What could they expect to find on the app, in the book, that kind of thing?
So, I mean, I think that's the really beautiful thing about medicine right now is that there are so many ways to access information and care. So it used to be like you can only go in person to see somebody, even therapy. Like you just got to sit on the couch and like that's how you see your therapist. And for pelvic floor therapy, it's like you got to go find somebody in your clinic. But there are a lot of places in the United States that do not have a pelvic floor therapist in the area, or there could be really long waits, or it could be costly, or you just may not be ready to see someone in person. So my book is a great starting point. It's called Floored, A Woman's Guide to Pelvic Floor Health at Every Age and Stage. And you can get it wherever you buy books. And it's just a real guide to kind of understanding the pelvic floor, how it influences everything, not just from like peeing, pooping, sex, but how it changes during puberty and pregnancy and postpartum and perimenopause and menopause, and just kind of the things that we need to be aware of in this part of our body through every season of a woman's life. And then the app is really kind of very exercise-based. So it's if you don't have access to pelvic floor therapy, or you've graduated, or you're in therapy and you just want something at home to follow along, it's got weekly workouts, everything for strengthening, for painful sex, for perimenopause, for pregnancy, you know, and it just is, they're 10 to 20 minute workouts. I always think about like, how much time do I have? And it's not 45 minutes 3 times a week, unfortunately. But it's a really great starting point to do these training programs at home to help you start addressing symptoms or prevent symptoms that you may be experiencing. So it's, you know, you can find it on Apple or Google. You can find it on my website, thevaginawhisperer.com, and just a great way to kind of get this training into the hands of women at a very accessible and affordable, way, because we can't all make it to therapy, but yet we should have this education and training.
What an awesome way to fill the gap for women.
Yeah. I mean, that's the hope. And I think that it's one of those things where there's so much information out there. I think it can be really hard to kind of peel our way through it. And so a lot of this is like, there's a quiz that you take for the app in the beginning to say, like, what stage are you? What do you need help with? To kind of hold your hand a little bit through the process, because it can feel very overwhelming. And then nothing beats in-person care, but I think we also need to meet women where they are and what they can access, and give them different options to work on this part of their body.
It's very cool.
Yeah.
Okay. Before we run out of time, because I think we have to wrap things up, what is your pelvic floor hot take?
Well, we already mentioned one of them is don't push when you pee. So I want everybody to, like, you know, follow up on that and think of me every time. You know, I think the biggest thing is it's never too early and it's never too late. I see a lot of women who say like, oh, but I had kids 20 years ago, or I'm already in my 70s. Like, what's the point? I'm like, if you are living your life, you should be taking care of this part of your body, because it is it deserves care. It's constantly evolving and changing during every stage of our life, and we need to care for it. And when we don't, it really can affect so many things that are important to us: our relationships, our self-esteem, our confidence, but even our ability to travel, our ability to be with our kids or our grandkids and jump in the bounce house or run on the soccer field or go on a girls trip because, you know, you don't have to worry about where a bathroom is, or start dating somebody new. I mean, I don't think we think about how this part of our body can really kind of weave into different aspects of our life until there's a problem. So I always tell people it is never too late. I've had women in their 70s, 80s, and 90s come see us, and they are still benefiting from it. But the number one thing they say is, I wish I would have started this sooner.
I think we hear that a lot too, huh, Dr. Robyn, with hormones and stuff. It's a area of neglect for a lot of women, I think, unfortunately. Okay, well, for our lovely listeners, we are so glad that you could join us today with Dr. Sara Reardon. She is the Vagina Whisperer on Instagram, on TikTok, on YouTube. She has her own website. She has a book. It's called Floored. She also has an app. It's called the V Hive. If you want to try it out, you can try it with our code. It's Parlor, Parlor. You can try it for 30 days. It's an amazing thing. If you've been listening, you'll hopefully see why pelvic floor therapy is so incredibly important. Dr. Sara, a huge thank you for joining us today. We really do appreciate it. We have so many women in perimenopause and menopause who struggle with vaginal health, vulvar health. We really do appreciate you joining Dr. Robyn and myself today to talk about this stuff.
Yeah,
Thanks for having me.